By the slide, kakku hol bana lage.
Mukh bonwa, Jaman Sarok bonwa, Ranjana bonwa.
Now we are live, huh?
Jaman Sarok bonwa.
Hold.
Meeting is on live, Baido. Baido, you can start.
Okay. Shall I start now?
Yes, yes.
Bisho record korisa niki, Muriat record no hobo de. I'm doing it. Baido, unmute yourself. Baido, unmute yourself. Sagata Baido, unmute yourself and.
Okay. So, dear all, good evening and welcome. After a thought-provoking deliberation of our last classroom, we are all excited to hear our speaker, Dr. Nitesha, in this second module. So, well, the NABOI, as you all know, is an unique body of the 7 northeastern states, and such unity and brotherhood will not be seen anywhere in India. As a president, I am lucky to represent all of you and pray God Almighty that our this unity maintain for all times to come. Coming back to today's session, in today's module, we are going back to basics again, and the talk is on the commonest subject, chronic otitis media squamous type, its management. And speaker is our dear Dr. Nitesha Moirengtham, the new generation talented surgeon who represents the state of Manipur. The session will be moderated by our beloved Dr. K. Jaman, a gentleman surgeon of Itanagar of Arunachal Pradesh, who doesn't need any introduction among NABOI members. Dr. K. Jaman passed MBBS from Assam Medical College in the year 1976 and MS in the year 1980 from same college. He received Fellow of International College of Surgeons in the year 1984 and FCMS in 1990. He also received prestigious Governor's Gold Medal in the year 2005. He was the past president of NABOI, had few publications in national and international journals. He was a pioneer of 3 flaps myringoplasty, which was published in Journal of Laryngotology in the year 1987. He is the pioneer of micro-ear surgery and also pioneer of cleft lip and cleft palate surgery in Arunachal Pradesh. He is also one of the reviewer of Indian Journal of Otolaryngology and Head and Neck Surgery, also a founder member of FHNO. Presently working as honorary senior specialist at Ramakrishna Mission Hospital, Itanagar, since 1981. So now may I request Dr. Jaman to introduce the subject and speaker. Jamanda, please.
Jaman sir, you are not audible.
Dr. Jaman.
Hello.
Yes.
Am I audible?
Yes.
Yeah. Good evening, everybody. Hello.
Hello.
Yes, sir. Yes, sir.
Yes. Welcome, Dr. Taman.
You can hear now?
Yes.
Okay.
Hearing you. Go on.
Okay. Thank you very much, Professor Swagata Khanna, for your nice words. Good evening, everybody. We are here today with a presentation by a brilliant doctor from Manipur, Dr. Moirangthem Nitchor, on chronic otitis media, squamous type, its management. Under chronic otitis media, squamous, if it is inactive, we talk about retraction of pars tensa and pars flacida. And in case of active squamous chronic otitis media, we speak about the cholesteatoma. Cholesteatoma is probably one of the very few conditions in the body with as many controversies regarding its name, definition, genesis, and pathology. The indispensable starting point is the pressure of an inflammatory process of the upper airways and the middle ear cleft mucosa. The growth pattern of the cholesteatoma is detected by the site of origin. The most common site are the pars flacida and the posterior superior quadrant of the pars tensa. The diagnosis of cholesteatoma is essentially clinical and treatment is surgical. The primary aim of surgery is to provide a disease-free dry air. However, keeping with the changing clinical profile of the patient presenting with cholesteatoma, it is important to also aim for a functionally better ear. With this little introduction about the topic today, let me introduce our speaker today, Dr. Moirangthem Nitchor. Dr. Moirangthem Nitchor completed MBBS 2005 from Regional Institute of Medical Science, worked with Medicine Sans Frontiers, Holland, Doctors Without Borders. He passed MS ENT in 2013 from Regional Institute of Medical Science, Imphal. He got first position in MS University Examination 2013, first position in selection exam of the Doctors of Manipur Public Service Commission 2010, recipient of Ascensama PG Awards 2012. He was under training for 2 years in advanced ENT and skull-based surgery at Jain ENT Hospital, Jaipur, under Dr. Satish Jain. He did cochlear implant fellowship under Dr. Milan Kirtane in Mumbai. He has done cochlear implant surgery under the guidance of Dr. Kirtane also. He attended dissections at Center of Excellence for Minimal Access Surgery at Bombay. Currently working as a ENT consultant at Sija Hospital, Imphal. Dr. Moirangthem Nitchor, with this kind introduction, I request you to start your presentation. Dr. Nitchor, please.
Thank you, sir. Thank you so much. Thank you, Swagataman. Thank you, Jaman, sir. Thank you, Neboy, and a very good evening to all the senior faculties, my teachers, my seniors, and my friends. Today, as we all know, chronic otitis media is such a poorly understood subject. Madam, actually, my screen sharing is not. And to understand this pathological process and to manage its this problem, we really need to understand the pathological process. So first, what I would like to do is I would like to focus on the pathogenesis of the chronic otitis media squamosal type or the Cholesteatoma, and then we will proceed to the management part. Yes, now I can do it. And I would also like to thank Neboy for giving me this opportunity to to present this very controversial topic. So coming to the coronary arteritis media, with this presentation, what I would like to do is, sorry, what I would like to understand with this presentation is we would like to understand the origin of cholesteatoma, the physiologic and the physical roles of the gas exchange that's occurring in the middle ear cleft, the system's vulnerable points and compensations that occurs when a negative pressure develops, and how this system reacts when its defense mechanism fails. And followed it by the different management strategies that we have. I'm sorry to inform, but due to the time constraints, the complication and its management of the cholesteatoma will be out of the scope of this discussion. I would also request the organizers to extend if the time falls short, and since it's a very vast subject, I would like to focus more on. Now coming to the prevalence, according to World Health Organization, around 65 to 330 million people are already affected by cholesteatoma, and then this coronary arteritis media, and then this cholesteatoma is a term which is coined by a German physiologist, Johannes Müller, in 1838. So when the human evolution starts, or the terrestrial life starts, the middle ear started originating in the vertebrates when they become terrestrial. Now in fish, this sound is sensed by water in the water by the cell-bearing population along the lateral lines. But as animals starts living extraterrestrial or terrestrial life, this cilia, which moves in the fluid, is replaced by auditory cilia, which is surrounded by endolymph and perilymph in terrestrial animals. And again, the sound waves that comes in the ear and then hits the liquid medium, more than 99% of the sound waves is bounced or it reverts back, it's deflected. So in order to preserve this amount of deflection, an amplifying system that we call the middle ear system has appeared. And in order to properly function the middle ear, we need minimal friction, as well as we need an inert medium where this system can work. And because of this, this middle ear system gets in a gas pocket. So middle ear aeration pathway, as we all know, the air starts coming from the eustachian tube, and then it goes to the protympanum, and then through the isthmus, it goes to the epitympanum, and then to the epithys, and then to the mastoid. So we can simply say this is the middle ear aeration pathway, but however, there are very different and various types of mucosal folds in the attic, which many times directs the entry of the air there, or it causes obstruction and causes negative pressure in certain segments of the middle ear, especially the epitympanum. But again, if we have to let the air pass through the middle ear, then there has to be a connection between the epitympanum and the protympanum or the mesotympanum. So this epitympanum and the mesotympanum, it is there are some connections in the this diaphragm, that is the anterior isthmus and the posterior isthmus. And when there is a space or a defect or a hole in the tensor tympani, then that also serves as a ventilation pathway. Now, Prusack space is very important because most of the epitympanic cholesteatoma starts in the Prusack space and is bounded by the neck of the malleus, the lateral malleolar fold, the pars flacida laterally, and the posterior malleolar fold, and it can when cholesteatoma starts in this area, it can go past and come down into the middle ear through the posterior porch of bone growth. That is how it can be. And as such, there are 4 theories to trying to explain the origin of cholesteatoma. The first one is the retraction pocket theory, which is described by Bizols in 1890, and the second is basal cell hyperplasia, or where the proliferation of papillary cones in the basal layer, and described by Rudy in 1917. And the third is immigration, where it says the epithelial ingrowth through a pre-existing perforation. And the fourth but not the least is the metaplasia, where the cuboidal cells or the ciliated cuboidal cells of the middle ear gets transformed to keratinizing squamous epithelium. So now in 2010, a major breakthrough has happened. In 2010, there was a study published in American Journal of Pathology, where Yamamoto and Fukuda did this study in gerbils, which are the only non-human animals to develop cholesteatoma. So in that study, they have clearly demonstrated that epithelial cells in the cholesteatoma are derived from the tympanic membrane and not from any middle ear cells or in the epithelium from the ear canal skin. And this they have published in 2010 in American Journal of Pathology. Now, if we come to know about the pathogenesis, it's an interrelated or interplay between eustachian tube function, a transmucosal gas exchange, and mastoid buffer that maintains the middle ear pressure and homeostasis. Now, when there is, middle ear pressure changes is there due to the ventilation root blockage or because of acquired fall or congenital fall, and since the middle ear space or the middle ear cleft is bounded by the bone, it cannot change in dimension every now and then. So certain features develop. How these features develop can be described by starting with the a similarity of middle ear cleft along with eustachian tube as a miniature lung. So how this miniature lung how the similarity is described is, see, the trachea in the lungs is equivalent or similar to the function of the eustachian tube, with the ciliated mucosa which clear of the mucus and then air passing through it. And then the alveoli in the lungs is equivalent or similar to the middle ear cleft and the mastoid where the gaseous exchange takes place. Now, in order to maintain this gas pocket, there are 2 main problems with the middle ear system has to come across. The first one is how to maintain its gas volume, composition, and pressure. This is very important. And the second one is how to keep this system clean. So in order to describe this process, we have to understand Hilding's experiment. What we can learn from him is, in Hilding's experiment, what he did is he took a piece of hen's trachea and then connected with a manometer and then blow the other end. When mucus which stays in the trachea and it is transported to the other end by the mucociliary action. When this mucus starts going to one direction, there was a negative pressure that is generated in that mucus, in the space where the mucus occupied before. And when this negative space or negative pressure increases and becomes equivalent with the force of this mucus transportation, then the mucus stops transporting. Then when the mucus stops transporting, he gave a nick in the trachea, and that nick served as a hole from which the external atmospheric air passes inside, and then the negative pressure is equilibrated. And then when the negative pressure is equilibrated, again the mucus movement started. And this we can understand it with what the middle ear and the eustachian tube has been doing when there is a mucus collection in the middle ear. When there is a mucus collection in the middle ear, the eustachian tube cleans the mucus by transporting it to the nasopharynx. Now, when the negative pressure develops in the middle ear, the mucus cannot be moved. So the easiest way to to let the mucus move again and clean the system is to make a small hole in the tympanic membrane and let the air come inside, equilibrate the pressure, and then the mucus starts moving again. This makes the system work again. So it cleans it, and then it again makes it happen. I am trying to find a... Now, if we study the role of adenoids, many a times we have thought before, but then it has been established now that the adenoids doesn't play an obstructive role in the gas exchange or the transfer of the gas from the eustachian tube to the middle ear. But it does plays an infective role, and that is when the infection spreads from the nasopharynx to the middle ear through the eustachian tube. So after many studies, it has been established that secretory otitis media recovers much better after adenoidectomy with a ventilation tube insertion rather than without adenoidectomy and only ventilation tube insertion. So when we try to identify and understand the gas exchange, we need to understand some general principles, the physical or the physics of gas exchange. That is the total gas pressure. The total gas pressure inside a cavity or an ambience is equal to the sum of the different partial pressure of each gas composition of that system, whether it be in middle ear cavity or whether it be in blood. So yes, what we see is this one partial pressure of oxygen of 150 mm mercury and partial pressure of water, and then this nitrogen partial pressure of 563 mm mercury is the sum of all these three components is equal to 760, which is the total gas pressure. Now, if we understand this, the next thing that comes in our mind is, see, when the partial pressure of oxygen, when it reaches the arterial pressure from the alveoli, there were about 93 mm of mercury. Now, when it reaches the mixed venous blood, then this 93 mm of arterial mm of mercury in the arterial blood gets decreased to 38 mm mercury. So this difference of 55 mm mercury is down in the mixed venous blood because the oxygen is utilized in the metabolic process. At the same time, the carbon dioxide is supposed to come out. It's supposed to come up, but however, the carbon dioxide level is only increases to about 5%, from 39 to 44%, 44 mm mercury. So there is a deficit of about 50 mm or 55 mm mercury. Now, in this whole process, the partial pressure of nitrogen hardly changes. As you can see, the 575 to 575 hardly changes. However, the total pressure of the total pressure changes from 760 to 704. So a difference of about 55 or 56 mm mercury is there. So this 55 or 56 mm mercury difference in the pressure change, it is directly the middle ear has to cope with it. How the middle ear has to cope with it? Yeah, this water vapor, water and carbon dioxide diffusing into the middle ear and oxygen diffusing into the circulation equilibrates so fast, relatively fast, that there is a sudden change in the pressure. But then this nitrogen, it's very slow to diffuse and it lingers in the middle ear, as well as it hardly takes part in the metabolic process. So the pressure, the partial pressure in the partial pressure of the nitrogen in the middle ear is increased to about 623 mm mercury. So this 623 mm mercury, increase in partial pressure, it gets absorbed in the blood slowly because of this pressure difference till middle ear inhalation, that is excess gas which comes from the atmosphere to the, or from the nasopharynx to the middle ear comes and equilibrates the pressure through the eustachian tube. Now, normally this process repeats itself again and again. So it has been estimated that about 1 to 2 ml of gas enters from the nasopharynx into the middle ear in a 24-hour period. We can also assume that the equal amount of gas is lost through diffusion from the middle ear to the mixed venous blood. So without some sort of ventilatory mechanism, all this negative pressure developing in the middle ear, it will cause either shrinkage or a collapse of the middle ear structure. Thus, the eustachian tube is served as a pressure equalizer of the middle ear cleft. So to summarize the gas exchange, the final middle ear gas composition is always virtually nearly similar to the venous blood in the middle ear. So middle ear is it can be said is a poorly ventilated gas pocket, and the diffusive exchange of the gases with the blood and the middle ear, it plays a greater part than eustachian tube inhalation, because eustachian tube inhalation is secondary to the negative pressure that is developed because of the diffusion from the diffusion of the gases from the middle ear to the bloodstream. Otherwise, if it's only straight away passing of the air, the middle ear gas composition should have been equivalent to the atmospheric gas composition and not to that of the venous blood composition. Now, how the mastoid act as a physiological pressure buffer is, we need to understand Boyle's law to understand this one, because Boyle's law says that a pressure of a given quantity of gas in a space is inversely related to its volume. So when the volume increases, the pressure decreases. Pressure increases, the volume decreases. Now, this middle ear gas volume is about 0.5 to 0.6 ml. However, the mastoid gas volume is about, the mastoid total volume is about, from 1 ml to 30 ml, depending on the different pneumatization of the mastoid. So this also it is lined by a thin, flat epithelium with relatively sparse blood vessels. So the gas exchange is less as compared to the middle ear. So the total volume or the pneumatization of the mastoid has such immense value. When the mastoid is sclerosed, the total volume is decreased. So a 1 mm or even 0.02 ml, ml change in the pressure will result in a huge pressure difference in a sclerosed or not well pneumatized mastoid. However, in a well pneumatized mastoid, even though there is a change in pressure, it hardly gets reflected in the overall the pressure of the middle ear cleft along with the mastoid. So it serves as a something like a pressure buffer in between. When there is a changes, in the pneumatized mastoid, there are many buffer systems. The space itself acts as a buffer, and it lessens the MAONO effect it gives to the middle ear. So understanding this problem and applying it to the infant who lacks most of the mastoid pneumatization, and these infants, they suffer a lot more episodes of exteriorization media or secretory otitis media much more frequently than the adults whose mastoid have matured. Now, when the middle ear, gets developed in when the negative ear pressure gets developed in the middle ear, the first structure, since the middle ear cleft is surrounded by bone, the first structure and the weakest of the structures to get retracted is the pars flacida. And the total volume displaced by pars flacida, it's about 0.05 ml only. So approximately 5 mm of water will be equilibrated by retraction of the pars flacida. So according to different grades of negative pressure, the pars flacida can be retracted and can be graded like type 1, type 2, type 3, and type 4. However, if the negative pressure persists and it comes beyond the pars flacida, the second structure to get retracted is pars tensa. But see the difference. Pars flacida, it can equilibrate only about 5 mm water of pressure, but the pars tensa, it can buffer up to 35 mm of water. This 35 mm of water, if continuous pressure, negative pressure builds up and then persists in the middle ear cleft, now it has got a damaging effect on the collagenous structure or skeleton of the pars tensa. So once the collagenous structure is lost, the pars tensa will become a non-rigid athelactic flabby membrane as in pars flacida. So as time passes and as the negative pressure passes, it turns into a retraction pocket, and then later on it turns into a cholesteatoma. Even the ossicular chain may be affected. So how compensation and decompensation work is, the first thing, when negative middle ear pressure builds up in the middle ear, is pars flacida retraction. If not corrected with pars flacida retraction alone, then pars tensa retraction comes up. Now, even if pars tensa retraction, if it becomes, the negative pressure becomes persistent, then eustachian tube opens up and the air gets gushed inside through the eustachian tube opening, and then the negative pressure is released, and this cycle keeps on. But suppose if the negative pressure keeps on coming up, and according to Starling's hypothesis, if the difference between the middle ear negative pressure and the summation of blood capillary hydrostatic pressure with the colloid osmotic pressure, if it's more than 50 to 90 mm mercury, then the serum transudate starts filling up in the middle ear. Now this serum transudate, what happens is, it occupies the middle ear space, and since it is incompressible, since the fluid is incompressible, it leaves very little gas pocket for any appreciable negative pressure to start developing the retraction. So in this view, this secretory otitis media can also be viewed as a protective mechanism to prevent from developing retraction pockets. Now, what if this also fails and persistent negative pressure develops? Because of inflammation or infection, or because of the decrease in the pressure, if a perforation occurs, that even let's Sven Ingolstadt also says at Gottsam perforation, it acts as a ventilation tube, and then the pressure difference in the middle ear and the atmospheric, it equilibrates, and then the further process of retraction or development of cholesteatoma stops. So this perforation can also be viewed as a godsend, ventilation tube to prevent feature. Now, when it comes to petalous eustachian tube, petalous eustachian tube, it's about the prevalence about 0.3% of the entire population, but in about a third patient who has got TM metastasis and even a cholesteatoma has got a petalous eustachian tube. So by our common understanding, this petalous eustachian tube should be, the gas should be transferring freely through this petalous eustachian tube. But why this atelectasis and even cholesteatoma develop is because if we understand the Bernoulli's theorem or Bernoulli's effect, in the external or the lateral part of the middle ear, there is no airflow. That's the atmospheric. That in the atmosphere there is no airflow; it's stagnant air. But in the nasopharynx part, the air keeps on flowing back and forth because of our respiration. So according to the Bernoulli's effect, when a stream of air passes perpendicular to an open eustachian tube or an open space, rather giving the air to the space, it sucks the air out of the space, and that's how the negative pressure develops in the petalous eustachian tube. And because of this, regular transfer of negative pressure and movement of the TM. Again, the collagenous structure gets damaged and TM becomes more atelectatic. And even because of this negative pressure, even a cholesteatoma develops. Now, how do we prevent all this negative pressure and the mechanisms and the effect of this negative pressure in the middle ear? Now, this vicious cycle can only be broken today by bypassing the system of this ventilation, and that is a direct insertion of a ventilation tube and making or keeping the hole open by the insertion of this tube. So once the hole is made and the air passes freely, this poorly ventilated gas pocket, it converts into a well ventilated gas pocket, and this has to be done before a permanent adhesion of the pars flacida or a pars tensa to the inner structure happens. And this ventilation tube insertion or grommet insertion is at present probably the single, if not the only, effective treatment in the face of middle ear negative pressure before it becomes permanent. Now, when we come to the pediatric cholesteatoma is more aggressive because of the immature eustachian tube, the horizontal level of the eustachian tube, which facilitates TM retraction and cholesteatoma development. Now, in children, there is increased amount of growth factor, so cholesteatoma also increases faster, and then the faster rate of replication of the keratinocytes in pediatric population is much more than in adults. So, cholesteatoma is much more aggressive in the pediatric population. Now, when it comes to definition and classification of the cholesteatoma, the European Academy of Otology and Neurotology has defined cholesteatoma as a mass formed by the keratinizing squamous epithelium in the tympanic cavity and or mastoid cavity with subepithelial connective tissue and by the progressive accumulation of this keratin debris with or without a surrounding inflammatory reaction. Now, this is the definition given by the. Now, again, there is a new classification system which is adopted by European Academy. And now the cholesteatoma, previously it was only congenital and acquired. Now there are three classification: congenital, acquired, and unclassifiable, where it cannot be classified whether it's a congenital or whether it's a acquired cholesteatoma. Now this acquired cholesteatoma, again, the European Academy has dumped the primary or secondary acquired terminology. Instead, they started using a new terminology of retraction pocket cholesteatoma, and this retraction pocket cholesteatoma can be a pars tensa cholesteatoma or pars flacida cholesteatoma or a combination of both. Now, the another non-retraction pocket cholesteatoma is where cholesteatoma occurs secondary to TM perforation or following a trauma or a iatrogenic cause. post-surgery, there's always a chance of recurrence or a residual. Residual is when cholesteatoma is left behind, and recurrence is when a new cholesteatoma develops because of all these changes in the pressure regulating mechanism. Now, in order to simplify and stage the cholesteatoma across the world, the STAMP system has been developed by, again, the European Academy. So in STAMP system, S stands for difficult access site, whether it can be S1 like supratuberous recess, or S2 like in sinus tympani, and T stands for tympanic cavity, A stands for editors or attic, and then M stands for mastoid. So if we go for classification and staging, now we can be quite uniform in staging the cholesteatoma. And the cholesteatoma, the stage 1 is described as cholesteatoma localized in the primary side, whether it's attic, whether it's tympanic, in the primary side only. And stage 2 is cholesteatoma involving 2 or more sites, attic plus mesotympanic cholesteatoma. In stage 3, cholesteatoma is associated with extracranial complications like facial palsy, labyrinthine fistula, labyrinthitis, or different types of abscesses damaging, or canal wall destruction, or an adhesive, total adhesion of the pars tensa or otitis media. But in stage 4 is when cholesteatoma presents with intracranial complications like purulent meningitis, epidural abscess, subdural or brain abscess, or sinus thrombosis. Now, when this classification system, what it brings is it brings uniformity to the reporting as well as staging of the system. Now, coming to the clinical feature, we always know that the patient will come with complaint of hearing loss or scanty, false smelling discharge. With when we see there could be granulation or polyp in the middle ear, there could be otomicrosis. The patient can complain of imbalance or intracranial complications. So, to investigate, the first we do is otoscopy, and followed it up by microscopic endoscopic examination. We also do audiometry to know the status of the hearing. We also will do session 2 functional assessment because it is very important for the future. We can do culture sensitivity or fistula tests or X-ray temporal bone, XRCT temporal bone, and again MRI. MRI is coming in a big way actually. Excuse me. When we do culture sensitivity, the commonest organism is Proteus, and followed by Staphylococcus, and ICRCT temporal bone is again the gold standard imaging for cholesteatoma. It can assist in diagnosis, it can assist in staging, we can do surgical planning, and then we can also identify the impending complications or the difficult cases. Even we can prognosticate. Here in this, the first we can see in the first picture we can see erosion of the lateral semicircular canal. Second, we can see attic cholesteatoma. The third is cholesteatoma arising in the Prusack space, and so on. So this is very important for planning of the surgery as well. Now, when we come to the MRI, the development of diffusion within non-echoplanar MRIs has changed a lot of things. It detects a small residual recurrent cholesteatoma after surgery by seeing this high signal intensity lesion. Why this high signal intensity lesion? Because this MRI, it detects molecular diffusion of the water molecules. But cholesteatoma is a non-vascular structure. So instead of diffusion of the water molecule, it stays back, and then we can identify as a high signal intensity. We can also access the intracranial extension of the cholesteatoma, and very important point is it is likely to replace second loop operation in some patients. Echoplanar diffusion weighted imaging has a size limitation of 5 mm. It has got greater artifact and distortion, but non-eco-planar diffusion within MRI solves a lot of problem. It can detect up to 2 mm size, less distortion and less artifacts. We can also detect, we can also use lead post-gadolinium T1 with a sequence that detects residual cholesteatoma of as small as 3 mm. Now coming to the management, since now we know that the pathogenesis of cholesteatoma, we need to apply the same principle in the management system as well, which could constitute surgery, hearing aid, or no treatment at all. But supportively, what we can do is we can give oral toilets or topical medication. Now, the objective of surgery should be very straightforward, and the first one is eradication of the disease. So there's no compromise with this objective. Followed by hearing improvement, then we should have a epithelialized self-cleaning ear, and we should be able to prevent all types of complications. Now, surgical strategy is very, very important. When the cholesteatoma is, small, or is occupying only the most lateral part, or it's not extensive at all, then we can include it in a Tympanoplasty with eradication of the disease, and different grafting of graft like underlay, overlay, interlay, or total annular excision, or with a cartilage Tympanoplasty. And then with plus minus, or with or without ossiculoplasty. Now we can also do simple cortical mastoidectomy. It has got its own advantages, indications, and disadvantages. We can do modified radical mastoidectomy, which can be outside in or inside out, according to the experience, according to the advantages and disadvantages. We can, during this mastoidectomy, there are two thought process: the interiorization or the closed technique, and the exteriorization or the open technique. Now, in which condition this interiorization or the closed technique should be done? As we all know, mucosa is responsible for gaseous exchange along with a good eustachian tube later on. So when in any surgical process, when the mucosa can be preserved for future gas exchange, and the ear has got good eustachian tube function, we should always attempt interiorization or a closed technique. And this closed technique can include canal wall up surgery, canal wall down with soft wall reconstruction, and or canal wall down with obliteration. There are different obliteration can also be with canal exteriorization, but then there are many different types of obliteration that we can use. Now, exteriorization or an open is when the middle ear and the middle ear cleft and the middle ear or the mastoid air cells have been exposed to the external atmospheric air. So when should it be done? It should only be done when the mucosa cannot be preserved. When the mucosa cannot be preserved, whatever the gas enters through the eustachian tube, where it will go, it won't get absorbed. So there is no function of the gas entering in the eustachian tube also. However, this eustachian tube can still function as in a small way in the middle ear or the mesotympanum part, and in cleaning the system of clearing the mucus. Now, MRN can also be modified radical mastoidectomy, can also be associated with tuboplasty, laser, it can be balloon tuboplasty. However, there is no very definite advantages we can get out of it that I know of. We can also do radical mastoidectomy, or we can also do a subtotal petrosectomy with cul-de-sac closure. Now, simple mastoidectomy is what is: you open the drill of the mastoid bone or cortex, open the mastoid, and remove the air cells and preserve canal wall. It's done in cases of acute coalescent mastoiditis or meningoencephalic herniation in the mastoid segment, or as a preliminary step, or even in a second look surgery. Now, in closed tympanoplasty, there have been certain reservations. However, the indications include cholesteatoma in children where we want to avoid the cavity, or a highly pneumatized mastoid where the future gas exchange can easily occur, or in case where the mastoid exploration becomes essential, or a minor epitympanic erosion, or a mesotympanic cholesteatoma. In such cases, closed tympanoplasty can be done. However, there shouldn't be any reservation about the clearance of the cholesteatoma from the middle ear cleft, because as you can see in the third picture, there is even though the canal wall is preserved, the sinus tympani can be assessed through the posterior tympanotomy or an extended posterior tympanotomy, and it can be even accessed with retrofacial approach. See here. So there shouldn't be any reservation that some places cannot be assessed with this approach. As we can see in this, the canal wall is preserved, the mastoid is drilled, the cholesteatoma is cholesteatoma sac is identified, and then after removal of the cholesteatoma, whatever the defect is in the posterior canal wall, it can be repaired with fascia or a periosteum or a cartilage or bone, and then the grafting is done. But there are some contraindications which forbid us from doing canal wall surgery in certain cases where there is an unresectable matrix over the labyrinth or facial nerve or carotid or dura or sinus tympani. When the surgery has been done only in the only hearing ear, or when there is labyrinthine fistula or poor eustachian tube function or long-standing ear disease. Now, according to literature, the second stage or second surgery, second look surgery is always planned for canal wall up technique. It should be planned within 1 year, suppose say approximately 9 months to 1 year of after the surgery. Then of course depends on the primary surgery and the site of cholesteatoma. And the additional advantage of the second look is we can do second stage ossiculoplasty. And whenever we find the recurrence of the cholesteatoma, we should immediately convert it to a canal wall down mastectomy instead of sticking with the canal wall up. Now, in open tympanoplasty or exteriorization or canal wall down mastoidectomy, the indications include contracted mastoid because the cavity that we are going to give is quite small in contracted mastoid. When the disease is a large epitympanic erosion or a large epitympanic cholesteatoma, recurrence of the closed tympanoplasty occurring, or bilateral cholesteatoma, and very important is when the patient suffers from associated cleft palate or Down syndrome, and in the only hearing ear, or a patient with severe sensory neural hearing loss where the goal of surgery is to make the ear dry. Now, this canal wall down mastoidectomy can also be retrograde mastoidectomy, which we call it inside-out mastoidectomy, where we follow just the pathology and drill the bone only according to the requirement of exposure of the cholesteatoma. So less bone removal results in smaller cavity. However, we can also enlarge the drilling or the cavity as much as we can according to the requirement of removing the cholesteatoma. Now, modified Bondy's mastectomy is when there is an epitympanic cholesteatoma. When there is an epitympanic cholesteatoma and the ossicular chains are intact. So in modified Bondy's, the whole system is removed, the cholesteatoma is removed, but this area that serves the hearing mechanism is preserved. This is modified Bondy's mastectomy. The advantage is the hearing is preserved. and there is low recurrence, it can always act as a canal wall down mastoidectomy. It can be done in a single stage because the osteoplasty part is not required, and the real risk lies in inducing a sensory nerve hearing loss because of the ecosystoma, because the ossicular chain was intact. So radical mastoidectomy involves complete removal of the medial ear, including the sound triangular system, except the step-based foot plate, and eradication of the tubal function. Then that's why it's called radical. It should be done in elderly patient with non-serviceable hearing, and in whom the only goal of surgery is to obtain a dry and safe ear. Now, other indications can also be included, like cochlear fistulas or middle ear cholesteatomas, or difficult to reach deep sinuses or cholesteatoma with intracranial complications, and of course in some benign tumor removal. Now, subtotal petrosectomy. Now, indication of subtotal petrosectomy is in a canal wall down cavity with intractable inflammation, with granulation, repeated wet and infected cavity with no serviceable hearing, we can do a subtotal petrosectomy. Or where already multiple surgeries have been done with no serviceable hearing, recurrent cholesteatoma with huge mastoidectomy. Because of this huge mastoidectomy, it becomes a bit difficult to do canal wall up, because again recurrence is there. Again, canal wall down, it becomes a huge cavity. So subtotal petrosectomy can be done in such cases, and in sustained cerebrospinal fluid leaks, and in cases of large meningoencephalic herniation or extensive exposure of the middle fossa, or cochlear implant, along with in conditions where CSOM or cholesteatoma happens, and in as you all know, paradengliomas actions. Now here, very important point is cul-de-sac closure of the EAC of the external auditory canal skin is done with removal of all the squamous and the mucosal cells. Then the cavity is filled with fat, and the radiological follow-up of the obliterated cavity with MRI using, because since the fat is put there, we have to use fat suppression, and diffusion sequence is mandatory. Now, subtotal petrosectomy, as we can see in this picture, the skin flap or the skin is elevated. Now, this skin is sutured externally towards the external auditory canal, lateral side, towards the lateral side, and then this suture, it is reinforced with subcutaneous tissue, which is again sutured behind the suture. And the epithelium remaining in the external auditory canal has to be removed in toto completely, and then it has to be drilled so that there is no epithelium remaining in that segment. And when the cavity has been, these have been removed, the cavity is polished, the extraction tube openings should be plugged with either cartilage, bone chips, muscles, periosteum. There will be anything, but it has to be blocked. And then the cavity is filled with fat, and it is closed in there. There are many advantages and disadvantages of canal wall up and canal down cavity, but then I would like to skip it because we have already discussed part of it. Now, complication of mastoidectomy, there can be residual cholesteatoma, there can be facial nerve injury, there can be bleeding, sensory neural hearing loss, especially the high frequency losses because of the movement or the ossicular chain touching the burr with the ossicular chain. There can be vertigo when the lateral semicircular canals are eroded, and when inadvertent injury to the canals are done, and then infection, granulation tissue in the cavity, then brain herniation because of loss of bone in the tegment and posterior fossa, and then CSF leak. All these things can happen. The most important problem with the mastoid, canal wall mastoid, is the cavity problem. And the solution for this cavity problem is remove all the mucosa that causes whipping of the cavity. Partially obliterate cavity to make it small. drill the cavity, make it rounded, smooth, contoured with no bony overhanging, bony overhangs, because bony overhangs again impedes in the epithelial migration later on. And then the facial reach has to be low to allow again epithelial migration. The TM should be repaired. The meatoplasty should be adequate size. Epithelialization of the cavity should be rapid, complete, and without formation of granulation tissue. And one of the very important point is don't leave bare bone in the mastoid cavity. Always try to cover it with a split skin graft or a skin flap or subcutaneous musculoperiosteal flaps. It can be many things. Now, in order to decrease the size of the cavity and to prevent it from discharging cavity, the cavity obliteration or reconstruction can be done. But be very sure that all cholesteatoma from the cavity and epic has to be removed first. If there is any doubt that certain part of the cholesteatoma may be left behind, we should not attempt cavity obliteration. Now, it can be done with muscle subcutaneous tissue, fascia, tragal, cartilage, or conchal cartilage, bone chips. And hello,
Dr. Nishor.
Yes.
Please finish within 5 minutes.
Yes, sir. I will finish it off.
Okay.
We have come to the end almost. Now, skin flap can be corners flap or radial flap, the medial base or the inferior base, the fancy flap. There are many different pedicle flaps we can use: superiorly based, anteriorly based, the rumbo flap, toes, Hong Kong temporalis fascia flap, vulva flap. These are just to name a few. Bleeding, it can be hematoma may occur, flap necrosis, infection, granulation tissue, external canal stenosis, and many other obliteration materials can be used. Biocompatible material like hydroxyapatite, glass ionomer, plaster of Paris, etc. And this brings to the end of my presentation, and these are the references that I've taken. And thank you so much for the patient listening. Thank you.
Thank you, Dr. Thank you, Dr. Nishor. Hello.
Sir. Hello. Thank you so much.
Thank you, Dr. Nishor, for your extensive study on the subject and excellent presentation. It is really awesome to hear about the development of mucosal gas exchange theories and ventilation.
Thank
Your
you.
cavity obliteration presentation is really good. Cholesteatoma is a very vast subject, and within such a short time, you have presented it beautifully. Let me take the 2 minutes for sharing the slide. Can you you have unshared, no? You have unshared, okay.
Sir, couldn't hear you properly.
Hello.
Yes.
Sir, could you share your slide?
No, I could not.
So you are a host now. Co-host, you can share your slide. Bissell.
Yes, questions.
Already co-host,
Okay.
Hello.
Moderator can taken up the question. Please take up the questions.
I'll just take up. Hello.
Sir,
Hey,
sir,
you
you
are sharing-
shared a wrong window.
Is it? No, it's okay, I think.
No, you are sharing it in a different window. You stop sharing it. The different. You have to click the window which you want to share.
That my slides is coming in that. Okay.
No, your maybe it is coming in your computer, but not here in the
Okay.
meeting. You just stop sharing.
Okay.
এইটো window close কৰিব লাগিব.
Pura leave কৰিব লাগিব নেকি?
You just close কৰিব লাগিব sir এইটো.
Pura
Cloud meeting এইটো close কৰক sir. এতিয়া share screen যাব লাগিব. You just open the PowerPoint, whatever you want to show, you just open and minimize it and slide share again, click that particular window.
Or otherwise, Anjana, you can take up the questions and then discussion. Okay?
Yes.
Yeah,
Sir.
don't waste the time.
Sir, if you permit me, can I read out by the time you prepare to share?
Because he is not audible. Huh?
Sir, so SB Fukan sir has asked a question. Why the change of classification occurred to mucosal and squamous type? Natasha?
Actually, sir, there is no change of classification from mucosal to squamous. We were talking about only the squamous. The change in classification was previously we used to describe as primary acquired and secondary acquired. Now, this primary acquired and secondary acquired, it has changed to this retraction and this one.
Dada, apni bisok phone.
But mucosal and squamous, there's no change.
No, Nitya, sir, I'm asked about the tubotympanic and eticoenteral. Why it is changed to that classification?
Regarding this tubotympanic and eticoenteral, it is actually not in favor nowadays because previously it was safe and unsafe. Now it has been established the safe type of chronic otitis media can also give complication as unsafe. So the previous norms of being safe and being unsafe is no more accepted.
Yes, that is correct. Thank you.
Next question is from Akhil Sharma sir. When mesotympanum is like nose, the atic and the mastoid air cell system is like the lung. Maximum gas exchange occurs in the posterior superior part of the mesotympanum. It's just a comment actually. He has also mentioned that medullary cleft also coined as miniature lung. But the anterior inferior part is like nose and remaining part is like lungs. So any more questions? Akhil Sharma sir has got actually mentioned many things. Sir, can you unmute yourself and share your views?
Yes,
Or
Sanjana. Yeah. I have only given a few comments, probably which is not covered in the lecture. Now, the role of isthmus anticus and posticus at the diaphragmatic level is well established. The aeration occurs from the mesotympanum to the atic as well as to the mastoid air cells. It is said that one isthmus when blocked, then there is a pars tensa posterior superior retraction. And when both isthmi are blocked, then there is an atic retraction. That is what I wanted to mention.
Thank you, sir.
It's a reference from the book. Yeah, reference from the book. Yeah.
SB Fukan sir asked why cholesteatoma site is pars flexida and the posterior superior portion of the pars tensa.
Yeah. Because why it is pars flexida is because in whole of the middle ear cleft, the least the structure with the least strength is the pars flexida. Again, why the posterior superior portion of the pars tensa is because the blood vessels are maximum in the posterior superior part. So if there is any inflammation coming up, that area is the one which gets damaged first. So now that area becomes retracted first.
Raman sir,
You are correct, Nitya sir. Actually, the high blood supply of the pars flexida and the posterior superior part of the pars tensa imbibes infection to that area, causing the fibrous layer to be more thin and becomes a pocket and for a chance of cholesteatoma. Thank you very much.
Jaman sir, are you there? Jaman sir? Jaman sir?
I think he has lost the.
Yes, he's.
Yeah. Can I get in, please? Swagata?
Yes. Hello,
Yeah.
hello, Dr. Prakash. And Dr.
Hi,
Prakash.
hi.
Yeah, hi.
Basically, I was listening to the presentation, no doubt about it. But see, the CSOM surgery or cholesteatoma surgery, I just want to make some observation and
Yes. Please.
based on my 30 years of experience of working in a center, which if it is not a very high pressure, it was a moderate pressure. We used to do a lot of surgery and so I have some experience and I would like to share some practical points. Excellent presentation. I mean, the young chap has made all the theoretical things very correct. When I listen to all these, sometimes some of the things which will bother me actually, and I discussed with most of the veterans of the day who are masters, who are the teachers, and they do all agree and very much respect the thing. What is the number one? How we diagnose the cholesteatoma? The very old thought. Some of the seniors will agree with me. The foul smelling ear is the first point which should attract your direction to I am dealing with a cholesteatoma, subject to your confirmation. About aeration part, we say adenoid, upper respiratory infection. In my 30 years of experience, what I have seen that has got a great role. If you clear the nasal cavity and the adenoid, that means if patient can do a good Valsalva, I think 99% you won't have a ventilation problem unless and until it is iatrogenic by our surgery. Number 3 point, I will like to say what is the purpose of surgery? Cholesteatoma, yes, surgery is required. What is patient's greatest expectation? If I do a surgery and still ear is discharging, is it acceptable? Probably not. So the first and foremost, I assure my patient, I guarantee a dry ear. What I cannot guarantee, that hearing cannot be guaranteed because there are a lot more involvement and I may have to go for a second stage surgery to improve the hearing. So to achieve the dry ear, what is our most important part? We should go to the nook and corner and find out the hidden cholesteatoma. Easiest way is to follow the disease. Follow the disease. Once you follow the disease, don't leave it in between. Almost 99% you can eradicate full of the cholesteatoma. Secondly, we talk a lot about cavity problem, this and that. Why there is a cavity problem? It is not the size, but it is the drainage. If you have done canal wall down, which we used to do a lot number, and still I say, if I have to guarantee a dry ear, even if patient is lost to follow up, if I do a canal well down with a good drainage, as speaker has already mentioned, what are the pitfalls where the drainage is. So the few hints I say, your ridge should be, posterior bony walls should be to the floor of the ear cavity. Number two, there should be no ridges, it should be a smooth cavity. And if you put some fluid, it should easily drain. and patient is taught in the post-op period how to clean that mastoid cavity. Over a period of time, if you have done a good mastoidectomy and no cholesteatoma left, 99% of the cavities become smaller, 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 and 10 years down the line, you may hardly find a cavity. These are some of my observations. And last but not the least, follow the method you are most comfortable with. Don't try to change your method every day because it takes time to graduate. Thank you very much for my patience hearing. Am I useful to this
Yeah. Thank
discussion?
you.
Thank you so much for the comments.
Yeah. Thank you so much. Very good information and very good educational, and I think it is a very academic.
Thank you, Prakash Munkar sir. Thank you very
Thank you,
much.
sir. Thank you, sir.
Thank you.
About Northeast, one more point I would like to say. Nowhere we say seven sisters, Many
Yeah.
times we say twin states, like Bihar, Jharkhand is a twin state.
Jharkhand.
But seven sister, that is a holding. I had the opportunity to visit Guwahati and Shillong and will in future definitely like to come to all of you individually given an opportunity. It's
No,
a nice
Munkar sir,
interaction with you all. Yes, sir.
Prakash Munkar sir.
Yes,
Actually,
sir.
Sagata has left one state. Sikkim also introduced. Actually, 8 states,
Yes.
not 7.
Yeah.
No. Long back in 2000, probably 4 or 6, I had a Eastern Zonal conference, and then I
Right.
invited all the seven sisters and some of the people from Guwahati and Sikkim, and somewhere people came. Though number was less, it was done in our state. So I think I always said Eastern and Northeast are the same. Let it be same. I belong to Eastern region, and Eastern, Northeastern, we are always the same. Thank you very much for your kind permission to listen me. Thank you.
Thank you.
Hello.
Yes, Dr. Jaman. Is there any
Hello.
question
I'm
left?
sorry. I'm sorry. I'll just share my screen for 2 minutes.
Okay.
Okay. This is actually, I am sharing this for the classification of Cholesteatoma.
Yeah.
Classification. And this is actually, this is that it scores are given 1, 2, 3, 4 like that, according to that involvement of the Cholesteatoma. This is 1 year phase. Number 2, 4 is middle year and epic. 3 is extensive destruction. Like that, they score it, and they give the scores, and accordingly the involvement, they make it the point. If it is 2 points or 3 points like that, then they stage it. Say this as the EO. This is already described by Nisho. This is in comparison to the college classification. Okay.
Okay.
So here actually this is they have simplified the whole thing. So I thought that it may be useful. So I'm sharing it. This classification is already described by Nisho. So yeah. Then some there is a framework of tympanoplasty surgery. So this is a semio-eto. Semio-eto means this is actually uh, is S for stage of surgery, A for approach, M for mastoidectomy, E for external canal reconstruction, O for obliteration of mastoid cavity, and ETO is access to middle ear, and T tympanic membrane, and O ossicular thing. So they classified the whole thing like this. So this may be useful for documentation and comparison of the individual study. Okay. This is semio-eto framework. So lastly, this is a little bit of take-home messages. This is a pathogenesis. Pathogenesis of cholesteatoma remain uncertain. Essential to possess the basic knowledge of the important anatomic and functional characteristics of the middle ear for successful management of cholesteatoma, and careful and thorough evaluation are the key to the early diagnosis and treatment. The treatment is surgical with primary goal to eradicate the disease and provide dry ear with a functionally better ear. Surgical approaches must be customized to each patient depending on the extent of the disease. Surgeons must be aware of serious and potentially life-threatening complications of cholesteatoma, and we must be aware of the post-year discharge for quite a long time, and which requires a prolonged follow-up. So I thank you all. I thank the organizers for giving me the opportunity to moderate the session. Some getting tough in between because of this network problem and others. So I thank everybody. Okay, I hand over the mic to Anjana.
Jaman said, by the time you stop sharing your screen, there were few questions. How much IL-1 alpha and TNF alpha responsible for osteoclastic activity of cholesteatoma?
I could not. That is a question I have seen by I think Marcel has asked that. So I could not find it actually. That,
so
anybody else can help?
Dr. Nitesha, can you take up this question?
Not only this alpha TNF, there are many other enzymes and markers which have been described, and they are all related with the osteoclastic and osteoblastic. And it is a combination of osteoclastic and osteoblastic factors that causes the erosion of the ossicles and the bones. One process overcomes the other process. But exactly, what is the role of TNF alpha? I don't have much idea of the exact role of TNF alpha, but I can find out.
Hello.
Hello. Hello.
I have put the question not to embarrass you, because this is the article, recent article of our Indian journal of January, February, March. The first article, original article of this. I studied in Indonesia, actually. There's TNF alpha factor and interleukin 1 alpha. They have categorized into two series, and they found the osteoclastic activities. He mentioned in Scott Brown 8th edition also, but they have studied these things. And a nice article. Therefore, I'm just to encourage that journal should be always go through the journal also recent. Thank you.
Okay, any questions? Anjana, is there a question?
Hello, interleukin 6,
Yeah.
interleukin 17, and
Yes.
beta also is
Oh yes, when there are many more. This study is only of the this interleukin 1 alpha and TNF 1 alpha. TGS, TGF also there.
One question has come.
Gautam has raised his hand.
Yeah, one question, just I want to read it out. What is your choice and technique of ossicular reconstruction in interiorization technique in situation of a number one, only long process erosion, number two, both malleus incus eroded, and number three, only cruras of stapes present? These are the three situations.
Thank you, Dr. Ranjan. My choice of ossiculoplasty is always cartilage, whether it be triangle cartilage or focal cartilage, but it's always cartilage. That's my choice of ossicular reconstruction. In only long process erosion, yeah, this is a very controversial topic, because there has been certain studies which says like if you connect these two, whether it be gas ionomer or whether glass ionomer, or whether it be type 2 and type 3 tympanoplasties, if you connect this, the process where this ossicular erosion has already started, but it keeps on going, or it may continue. So a certain segment, even if you contact, it may ossicular necrosis may occur later on also, and then the ossicular separation may occur. So it can be done as special modification that I used to do is I do partial type 2 and type 3, a combined effect. That is, we call it Herman's technique of osteoplasty, where the cartilage one end is placed in the just above the inferior annulus, and the other cartilage end is placed between the incus and the stapes head.
Okay.
So the ossicular chain also maintained, as well as the support of the TM also is there. We can also insert a simple cartilage in between, or we can even take out the incus and then do a complete type 3 cartilage tympanoplasty. Personally speaking, I hardly use ossicular or the remnant ossicles as a method of as the material of choice for ossiculoplasty. I'm a bit worried about the fixation later on. I'm a bit worried about the the retention of or the retained cholesteatoma in the ossicles. So there were some studies which was done by Wormel and some few giants in Otology, and they found around 17 to 23%, I think, if I remember it correctly. The ossicles that's been used in ossiculoplasty contain, strands or pieces of epithelium associated with it. So personally, I don't encourage or I don't do. In only crura step is present, we can do type 3 tympanoplasty with the L strut, or we can do vertical strut tympanoplasty. So basically, what personally I do is type 3 L strut and vertical strut tympanoplasty.
What is the role of canal wall reconstruction in post-operative canal wall down procedure, and also tell the role of Bondy's and transcanal mastoidectomy?
What's the role of canal wall reconstruction in post-operative? Canal wall down, what really affects the people is the weeping mastoid cavities and the the dependence on the ENT surgeon to clean the ear every 6 months or 1 year. So this is sometimes very disturbing to the people, as well as there are some postulations that once the sound wave enters inside the ear, and because of the mastoid cavity, it diverges all around. But in an intercanal wall, it the cavity problem issue is solved, as well as the sound when it enters in the same way as the previous normal ear canal. So the intensity and the integrity of the sound is well maintained. But moreover, it's related with the avoidance of the mastoid cavity and its related problems.
Okay, one more question. Is there any role of Jackler's theory 2015 in cholesteatoma formation? What is the classification of eustachian dysfunction?
Sorry, I have no idea of Jackler's theory. If you can, sir, if you can tell me the theory. Maybe I've gone through it, but then I don't remember it as Jackler's theory.
Ripamo, you can unmute and you can share.
Hello.
Yes.
Sir.
Okay. Jackler's theory is the extension of your mucosal retraction theory. That where there is in stage 1, there is coupling of the two opposing mucosal surface, and there is dragging of the tympanic membrane inward, and there is then trapping of the mucosa and the mucosal elements in stage 2, retraction, and then there is keratin formation. So this is Jackler's theory according to 2015. It is the 5th one. You have you have mentioned four types of cholesteatoma formation theory. This is the 5th one. This is the latest one.
Oh, okay.
2015.
Yeah.
So a lot of lot of questions are coming, but we won't be able to take up all these questions because of time constraint, or we can discuss it in Naboy forum, but Gautamda has raised his hand. Can you unmute yourself and share your experience?
Thank you,
Dr.
Anjana.
Gautam Khan.
Thank you, Anjana. I raised my hand because I have been unable to post a query. And thank you, Nitesh sir. It has been a very nice presentation. I feel you could have divided it into 2 parts and spoken on 2 days. It's such an extensive and nice subject. And also Zamanda for the slides. Nitesh sir, what I wanted to know from you, you had given us the indications of subtotal petrosectomy.
Yes, sir.
Can you tell me in which conditions, only about talking about cholesteatoma, where one would be advised to do an upfront subtotal petrosectomy? About in your slide, you have talked mostly about recurrent where the whipping cavity. You have talked about multiple previous surgeries and recurrent cholesteatoma with a used mastoid cavity, etc.
Yes, sir.
So where actually you would advise for?
Sir, if I have to, if you permit, can I share a short story? Because this I have discussed with many other very senior guys, senior people also.
Yeah, please.
I had a case of cholesteatoma in a child with a very contracted mastoid. But then what happened was in the imaging, we could identify the posterior canal wall, the tegmen, and the posterior, even the posterior fossa were pretty much destroyed. And extensive, the dura has been exposed. So again, in that child, I also identified the excision tube was bony blocked. I mean, like there was no cannulation or channelation of the excision tube. There was no channel at all or canal at all. So in that case, I took advice from some of my very senior teachers, and then what we have come to the conclusion is even if we preserve and we keep the mastoid cavity intact, what does it serve? The infection, it can always, since the dura is extensively exposed, it can always go back to the, intracranial part. As well as if the excision tube is blocked, there is not going to be any air supply coming in. And in other conditions where we can see in canal atresia and in temporal bone atresia, where all the structures are in a very malformed way, and extensive cholesteatoma staying in that cavity. There also we can do the subtotal petrosectomy. We can decide upfront before the surgery has been taken over. In conditions where there is a hearing component, if there is hearing component there, then what I would prefer is life first and other second. So I would do the procedure in such a way that I have to save the life of the patient first, and then keep it safe. And then if there is a residual hearing, we can always go for Baha and all later on. We can even go for a cochlear implant later on. But then for the time being, if those two are not being planned in the same time, I would prefer the subtotal petrosectomy, then clean and save the cavity, and then later on go ahead with the hearing preservation, hearing procedures.
Thank you.
I think two straightforward indications of subtotal petrosectomy are treatment of chronic otitis media in ears with severe sensorineural deafness.
Yeah.
So that is the first indication. And the second one is treatment of chronic otitis media prior to cochlear implantation.
Yes.
Yeah. Anjana? Yes, Anjana? Please unmute.
Okay. Before I finish, I'll read out 3 questions. Dr. Niteshwar, be precise is answering because of time constraint. 2 questions from Akhil Sharma sir. When repairing the canal, will you reconstruct the scutum? And for
Yes.
obliteration, what different techniques and materials do you use? What are the flaps used for repair?
Sir, in posterior canal wall retraction, the sputum reconstruction is always part of it, because we try to preserve the normal anatomy of the ear as much as possible. So sputum, if the sputum defect is kept in place, then again retraction pocket may also develop there because of the
Also the physiology, because
yes,
that is the
it
area.
can alter the physiology, and then again the same process may develop. So we
Because
always try to
then only the
normal
cuboidal cells in the upper part, in the posterior superior part of the major tympanum, as well as in attic also, it will start giving the gaseous exchange. So
yes.
that is very important to maintain that physiological process. If we do not close down that, reconstruct the attic wall, we cannot achieve it. And what is the second part of the question? What are
For
the different,
obliteration.
for obliteration, what are the different procedures do you use?
Generally, sir, this hard wall reconstruction and soft wall reconstruction has been generally described. What I personally prefer is always a soft wall reconstruction using a triangle or a concal cartilage later on. It can be reinforced with periosteum or the fascia and skin flaps. But then the choice of material that I use is always either a triangle cartilage or a concal cartilage. Because if the cartilage is kept, even if there is change in pressure, then as I've shown in my presentation, it won't be a narrow neck retraction. It will be a wide neck retraction. So that wide neck retraction will never develop a cholesteatoma, because everything can be cleaned out, and it has got this epithelial migration properties.
So last question.
In fact, it is not a such a short list.
The time.
Yeah.
Okay. If there is time restraint, I won't talk.
The last question of this Deboy classroom is from Madhumangal Singh sir. So
Yes,
with
yes.
that, we'll conclude the question answer session. How will you manage when the cholesteatoma is around an unstable or fistula tract around stapes?
The first and foremost is the cholesteatoma around the stapes can always be removed if we are very patient and we have a very fine heart and fine hand. Otherwise, it becomes very difficult to even for a normal individual like me to do the surgery. But suppose if there is again a fistula tract, what we do is we do all the bone works first and keep that area for the last. Finish all the bone wall first and keep the area for the last. And then when we focus on that, we have to be very gentle. There shouldn't be suction directly over the fistula. We have to maintain that the endosteum of the vestibule and these things are not touched or say violated. We have to be very sure that the stapes is not hypermobile, or there may be a fracture of the stapes foot plate as well. We have to again keep our fingers crossed to prevent any development of a sensory neural hearing loss later on post surgery also. But then again, if it's around the stapes, it could also be similar as doing a stepidotomy surgery, the effect, the post effect. So if we are gentle enough, not suck the endolymph and perilymph directly from the fistula, then probably we are pretty safe. And then that area can be covered with a vein graft later on. That area can be covered with fascia and even over the vein graft and the fascia, there we can put a cartilage columella. that will keep as a pressure over that area. So there are many different ways to deal with it, but again, sir, I have to say the exact area where the fistula tract is, that becomes very important in such management of such points or such diseases.
Over to Sagata, ma'am.
Yeah.
Okay.
Hello. Can you hear?
Thank you, Dr. Niteshwar. Thank you, Dr. Niteshwar, for an excellent presentation. And of course, it's an overview of your subject. The subject is very vast. You touch all the points. Yeah, and very well taken that the safe air is our prime indication, isn't it? And
Yes.
I think one part you have not mentioned that this is the bacteriology part, the role of bacteria in a discharging cholesteatoma. This is a very important point, and clinically we should be aware of this culture and sensitivity. You have already mentioned your case, but the role of bacteria is a very important thing to prevent the intracranial extension, intracranial spread of the disease. So this is very important. And Dr. Jaman, thank you very, very much for your sharing your knowledge in regard of the micro ear surgery. Thank you all the participants, and particularly Dr. Madhumangal Singh. Thank you very, very much for joining us. And as our secretary today is not present in this Zoom meeting, so I conclude here and wish you a very pleasant evening. Thank you very much. Thank you.
Thank you so much, and good night, ma'am. Thank you so much.
So